Hello everyone, hello my dear colleagues. I wanted to talk about special things. Due to some emergency problem, I changed my topic to this topic, and excuse me for that. Previously, I discussed some special things in case of panfacial fracture. As you know, it's disaster in emergency case of the hospital. And right now, I decide to bring for you some case series. Actually, it's my case series or group did the surgery for this type of the patient, and I wanted to discuss different modality of the close reduction in mandibular fracture in pediatrics, especially in pediatric department. It is case series and included 5 cases and different type of the surgery we wanted to discuss, and at the end I wanted to talk about which type of the surgery is useful. Excuse me, can I see previous slide? I want to discuss about our university. Second slide, I mean. I have a special thanks from the head of the department of the maxillofacial surgery, to Professor Sergey Yurevich, and also Dr. Sergey Sergeyevich from the department of the oral and maxillofacial surgery of the Ruden, to help me to collect all data from the hospital. And next page, please. As an introduction, I want to discuss about my article, which is with the same topic and already published in the Elsevier in Surgery Case Report journal. And here we have some introduction about the close reduction surgery. As you know, in the pediatric maxillofacial trauma, we have a lot of problem with the function and aesthetic of the patient. Sometimes the patient suffer from the pain and some aesthetic functional problem. In the future, the patient will face a lot of problem. And if you know, we have a lot of etiology due to this condition. The patient maybe from 5, 6 year olds, they have a lot of problem with soft tissue, the bone, the bony tissue, especially in the cranial part and the palatine part in our specialty didn't fuse completely. That's why we have a lot of problem. And due to high physical activity or emotional activity of the children, we may face a lot of case in the mandibular fracture. And the most cases, due to researches in the PubMed and Elsevier, are from parasymphysial and condylar region, especially condylar region. But right now in this article, we want to talk about the parasymphysial and symphysial fracture. They could be vertical, horizontal, multiple, or with some fragmentation there. Here we have not actually open actually fracture. Here we have closed fracture, not multiple fracture, only some vertical or maybe not completed fracture, and with favorable outcome. And the complication that the patient could have, or maybe some complaint of the patient, could be difficulty open the mouth. It's so difficult to actually visit the patient at this time. And malocclusion also is most common complication of this surgery. And also, we know that maybe open reduction surgery is the one method of stabilization of the jaw for the patient. But as you know, open reduction surgery, they may have a lot of bleeding or the risk of the cutting the artery, vein, or maybe nerve. And it is actually invasive surgery. That's why we want to decide to do other type of the surgery, which is non-invasive surgery. And here in the right side of the page, you can see our article, which is published already. I kindly invite you to read this article. I hope it be useful for you. Next page, please. Actually, here we have the aim of the article, which is to evaluate and comparison of the 5 different cases with uh, down completely closed reduction surgery, which is a non-invasive, and in especially in pediatric mandibular fracture. And at the end, we wanted to conclude which method is the best and gold standard in which cases, in which condition. And methodology, as you can see here, we have 5 patients. The range of the age is between 3 till 12 years old. And the type of the article is case series, and assessment is clinical examination and radiography. There is full text details about the type of the surgery and radiology. And the follow-up of the all patients is mostly 6 months, but one patient, I remember that we did follow-up for only 3 months. Next page, please. Here you can summary of the cases. The first case, actually, it is better to mention that all cases are boy, and the first case is 12 years old, second 4, 7, 3, and 5. And here you can see the fracture type bilateral. The first case is only the first case is some complicated case, unstable, as you can see here. The jaw of the patient fully fractured vertical, and it's not stable, and it's difficult challenge for a group to fix this type of the surgery. And in this case, we actually choose the two type of the surgery, IMF and arc bar. And the outcome was normal. And the patient after 4 weeks could try to eat some things, but slowly, and the rehabilitation of the patient was successfully. And second case, 4 years, male, boys, I mean, right parasymphysial, stable. The jaw of the patient was stable. The patient could open the mouth. I fully discussed about it in with picture and something else if is necessary. And we choose the maxillary mandibular arch bar. It is actually second um, way to discuss the type of the surgery. Till now, we have one type of surgery. And third case is a left parasymphysial stable patient. Only first case it was unstable. Other case was stable. Lower arc bar only. And the fourth case, left parasymphysial, again a stable patient, and interdental wiring. And the last case, which is um, left parasymphysial circummandibular wiring plus acrylic bar. And this is one thing to discuss the prosthetic for the patient. We create some things extra to fix the better fixation of the patient. I will discuss especially for this method. Next page, please. Here you can see the first case, the special case, the unstable patient, as you can see here. The fracture bilateral parasymphysial, the patient, as I discussed, vertical fracture. And this patient, you can see here the radiographic of the patient in the middle part in the figure number 4, middle up. As you can see, the point, red point here, excuse me, excuse me, next page, please. In the upper middle picture, you can see the vertical fracture in the bilateral side of the patient. And here you can see a town view radiograph of the patient, also suspected and confirmed. And here you can see the lateral view in the right upper picture. Here we can see two bilateral, but it's from the right side of the patient. And there is also other picture of the patient, intraoperative and postoperative. Let me discuss. Excuse me, can I see previous picture? Previous page, please. Uh-huh. Here, I want to discuss the patient came to the hospital with swelling, bleeding, and unstable lower jaw. And our team decide to do intermaxillary fixation plus arc bar, because the lower jaw from two sides fracturized, and there is a problem for stabilizing of the jaw in this case. And this type of the surgery successfully done, and after 6 months, no any complication, no pneumonia and malonion, and no other secondary infection or maybe secondary surgery. And here you can see the picture of the patient. Please, next page. Next page, please. Next page. One more. Okay. Case number 2 and 3. Why I bring these two cases together? Because these two cases are actually the same. It's not the same method. We treat these two patients with the same method: maxillary and mandibular arc bar, no IMF. Here, the second case and the third case, lower arc bar only. What's the advantage? Can you please show me the next slide? Here you can see the second case, which is a stable jaw and upper and lower arc bar, as you can see in the middle lower picture, figure number 13 in preoperative picture. As you can see, we fix all arc bar in upper and lower jaw, and the jaw of the patient is already fixed, and there is no any mobility for jaw and actually tooth. Next page, please. And here you can see the third case. It is also fracturized the lower jaw, unilateral parasymphysial, and is stable. That's why we choose the method for lower jaw, actually arc bar. Here you can see in the right side lower figure, the lower arc bar is fixed already, and the patient didn't face with any complication and malonion or nonion, something like this. Next page, please. Fourth case. In the fourth case, we face with the patient. As you can see, maybe is it possible to show me next page the picture of the patient? Yes. Here you can see the picture of the patient. The patient, 3 years old, came to the hospital with a stable jaw, and he couldn't open the mouth fully. Only one or two fingers of the specialist could insert to the mouth of the patient, and there is swelling of face unilateral, the side of the fracture, left side, as you can see here in the radiograph. In the lateral radiograph in frontal and oblique, you can see the confirmation of the vertical fracture in the left side between premolar and canine tooth. And here we did the interdental wire fixation. And next page, please. Okay, here you can see the post-operative radiograph, and in the left side you can see intraoperative after the immediately after the surgery, and the jaw already fixed, and after 6 months there was no any complication. Next page, please. I want to focus in type of the in actually dentition patient. If we face with some children in case of dentition, multiple dentition. I mean, there is primary and secondary dentition. That's why we should choose a specific method to say to preserve for preservation of the enamel organ or maybe test spot. I mean that. Next page, please. I wanted to show the specific things. Next, is it possible to show me next page? Okay, in the upper left picture, here you can see, if you focus it, the same color with prosthetic and the mucous membrane of the patient. But if you focus on that, we need to stabilize the patient. As you can see here, there is an acrylic bar and there is a wire inside. This type of the prosthetic is especially for the patient in case of the mixed dentition. And with this method, we can preserve all two spots of the patient, and the patient won't face any complication for malocclusion. These patients won't suffer in the future from malocclusion and don't require any orthodontic treatment. That's why it's a gold standard method for the patient in in a stable jaw fracture in case of the multiple uh, dentition. Next page, please. And also here you can see the conclusion of this article. The gold standard method is especially IMF, and this type of the surgery is especially for unstable or maybe stable also, but for stable I prefer to do the last method, which is a silicomandibular wiring and acrylic bar. Acrylic bar, as I told you, is in my mind, is gold standard method for preservation of the multiple dentition in pediatric. And here you can see the arc bar is the second method that we choose for a stable fracture. And the last method is circummandibular wiring that I discussed many times. The technique selection depends on the age, fracture type, and dental status, especially. In sometimes we will face with the patient who are who have some malocclusion already, and this is a problem for the patient, challenge for the specialist to fix this type of the jaw which already faced with malocclusion problem. That's why it's important thing to choose the special method for a special case. And the main finding, all these patients achieved fully functional and aesthetic recovery. This is a important thing for all these cases. And no complication, no any complication for the patient, and no any secondary surgery or maybe some orthodontic treatment in the future of the patient. No nononion and no malonion and infection for the patient. And the pediatric mandibular fracture management must be individualized, because from children to children we have a lot of difference. That's why we should discuss, especially in that case. And close reduction surgery was successfully an excellent outcome for all our patients, and it could be gold standard method for treatment of the patient. And at the end, excuse me, next page. Next page, please. I have a special thanks from your conference to invite me to join this conference. It was a good experience for me to be here with you, and I will listen other presentation. I hope my presentation was good and be effective for you. And also, I invite you to maybe work with me. I have a lot of research in case of the maxillofacial fracture, and I mean maxillofacial head and neck region. I have a special thanks from your conference, and thank you so much. And in next page, you can see other my article that you can see in future. Thank you so much.
Good morning, and thank you for the opportunity to present our work. My name is Eleni Litzou, and today I will present our systematic literature review entitled Post-thyroidectomy Swallowing Difficulties. This review focuses on the insistence, pathophysiology, risk factors, clinical impact, and current evidence regarding post-operative dysphagia following thyroid surgery. Thyroidectomy is currently among the most frequently performed endocrine surgical procedures worldwide. Although the procedure is generally considered safe, post-operative swallowing difficulties are increasingly recognized and in clinical practice. Importantly, dysphagia may occur even in patients without obvious recurrent laryngeal nerve injury, suggesting a multifactorial pathophysiology. Patients may report symptoms such as global sensation, throat discomfort, difficulty swallowing, coughing, or foreign body sensation. These symptoms may significantly affect postoperative quality of life and patient satisfaction. Both subjective patient-reported symptoms and objective abnormalities identified through instrumental swallowing assessment have been described in the literature. The primary aim of this systematic review was to evaluate the insistent and clinical evolution of swallowing difficulties following thyroidectomy. We also aim to investigate the temporal pattern of postoperative dysphagia, including the onset, peak severity, and recovery over time. Another important objective was to identify factors associated with persistent or more severe swallowing impairment, such as the extent of surgery, patient characteristics, and adjuvant therapies. In addition, we reviewed the available evidence comparing different surgical approaches, including conventional open, endoscopic, robotic, and minimally invasive techniques. Finally, both subjective patient-reported symptoms and objective instrumental swallowing assessment were examined. This study was designed as a systematic literature review following the PRISMA guidelines for systematic reviews. A comprehensive search was performed in the PubMed, Medline, and Cielo electronic databases. The main search terms include dysphagia, swallowing disorder, deglutition disorder, thyroidectomy, and thyroid surgery in different combinations. Both subjective patient-reported outcomes and objective swallowing assessment were included in the analysis. Objective evaluation methods included video fluoroscopic swallowing studies, fiber optic endoscopic evaluations of swallowing, ultrasound assessment, and esophageal manometry. After the screening and eligibility assessment process, 31 studies involving a total of 64,123 patients were included in the final review. The study selection process was performed according to the PRISMA methodology. After database searching and removal of duplicate records, titles and abstracts were screened for eligibility. Studies not meeting the predefined inclusion criteria were excluded. The remaining four full-text articles were assessed in detail for eligibility and methodological relevance. Finally, 31 studies involving a total of 64,123 patients were included in the systematic review. The pathophysiology of post-thyroidectomy dysphagia appears to be multifactorial and remains incompletely understood. Traditionally regarded laryngeal nerve injury was considered the main cause of postoperative swallowing dysfunction. However, several studies demonstrated that dysphagia may also cure after uncomplicated thyroidectomy with intact nerve function. Possible mechanisms include transient neuropraxia of the recurrent of superior laryngeal nerves, post-operative edema, fibrosis, scar tissue formation, and reduced laryngotracheal mobility. Objective swallowing studies have also demonstrated alterations in hyoid, bone excursion, and laryngeal elevation during swallowing. In addition, endotracheal intubation, trauma, muscular dysfunction, postoperative pain, and psychosocial factor may further contribute to symptom development. Overall, postoperative dysphagia should be considered a complex and multifactorial functional disorder. An important finding of the review literature was that swallowing difficulties are often present even before thyroid surgery. Reported prevalence of preoperative dysphagia varied significantly among studies, ranging from approximately 3% up to nearly 78%. Patients commonly reported globus sensation, throat discomfort, foreign body sensation, intermittent dysphagia, and difficulty swallowing salt foods. Compressive effects from enlarged thyroid glands or substernal goiters may partially explain these symptoms. Interestingly, several studies demonstrate improvement of pre-existing swallowing complaints following thyroidectomy, especially in patients with large goiters and compressive disease. Therefore, postoperative swallowing symptoms should always be interpreted in relation to the patient's baseline preoperative status. One of the most consistent findings across the literature was the characteristic temporal pattern of postoperative dysphagia. Swallowing difficulties usually increase immediately after thyroidectomy and reach peak severity during the first postoperative week. During the following weeks, symptoms progressively improve, with most patients returning to their baseline swallowing status within approximately 2 to 3 months. Several studies also demonstrate further recovery up to 6 months postoperatively. However, smaller subgroups of patients may continue to experience persistent dysphagia and reduce quality of life even in the long-term postoperative period. This temporal evolution supports the concept that most swallowing dysfunction after thyroidectomy is transient and reversible. In addition to patient-reported symptoms, several studies evaluated swallowing function using objective instrumental methods. The most commonly used techniques included videofluoroscopic swallowing studies, fiber optic endoscopic evaluation of swallowing, ultrasound-based kinematic analysis, and esophageal manometry. These studies demonstrate measurable postoperative alteration in swallowing physiology, particularly during the pharyngeal phase of swallowing. Reduced hyoid bone excursion, impaired laryngeal elevation, and changes in upper esophageal sphincter dynamics were frequently observed. Importantly, objective abnormalities did not always correlate with the severity of subjective patient complaints. This discrepancy further supports the multifactorial nature of post-thyroidectomy dysphagia. Several factors have been associated with an increased risk of postoperative swallowing dysfunction after thyroidectomy. The extent of surgery appears to play an important role, with total thyroidectomy generally associated with higher dysphagia rates compared with lobectomy or less extensive procedures. Additional procedures such as central or lateral neck dissection may further increase postoperative morbidity and swelling impairment. Older age has also been associated with more severe or prolonged symptoms in several studies. Patients treated for thyroid malignancy may experience greater swelling dysfunction due to more aggressive surgery and the need for adjuvant therapies, including radioactive ion or external beam radiotherapy. Finally, postoperative fibrosis, scar formation, and tissue adhesion may contribute to persistent long-term symptoms. Several studies included in this review compared postoperative swelling outcomes among different thyroidectomy techniques. Conventional open thyroidectomy remains the standard surgical approach worldwide. However, minimally invasive, endoscopic, and robotic procedures have been increasingly introduced in an effort to reduce tissue trauma, postoperative pain, fibrosis, and cosmetic concerns. Some studies reported improved swallowing outcomes and better postoperative quality of life with robotic or endoscopic approaches. Nevertheless, the available evidence remains heterogeneous and sometimes contradictory. Differences in surgical access routes, operative techniques, patient selection, and surgeon experience may explain these variations. At present, there is insufficient evidence to conclude that one surgical technique is definitely superior in preventing postoperative dysphagia. Postoperative swallowing dysfunction may have a substantial impact on patient quality of life even when symptoms are considered mild from a clinical perspective. Patients frequently report discomfort during eating, throat tightness, global sensation, coughing, and a fear of shocking. These symptoms may interfere with social activities, emotional well-being, and overall postoperative satisfaction. Several studies demonstrate that subjective swallowing complaints may persist despite the absence of major objective abnormalities. Therefore, patient-centered evaluation and adequate preoperative counseling are extremely important. Long-term follow-up is also necessary in order to identify patients with persistent symptoms who may benefit from additional evaluation or rehabilitation. Despite the growing interest in post-thyroidectomy dysphagia, the currently available evidence presents several important limitations. One major issue is the significant methodological heterogeneity among studies, including differences in study design, patient population, surgical techniques, and follow-up duration. Another limitation is the lack of standardized tools for dysphagia assessment. Many studies relied mainly on subjective patient-reported questionnaires, while objective swallowing evaluation were inconsistently applied. In addition, long-term follow-up data remain limited, making it difficult to accurately evaluate persistent postoperative symptoms. This limitation reduces the comparability of studies and restricts the strength of current conclusions. Future research should focus on standardized assessment protocols and high quality prospective multi-center studies. The findings of this review have several important clinical implications for both surgeons and patients. First, patients should be informed preoperatively about the possibility of temporary swallowing difficulties after thyroidectomy. Understanding the expected postoperative course may reduce anxiety and improve patient satisfaction. Most swallowing symptoms are transient and improve spontaneously within the first postoperative months. However, patients with extensive surgery, neck dissection, malignancy, or persistent symptoms may require closer follow-up and additional evaluation. In selected cases, objective swallowing assessment and multidisciplinary management involving otolaryngologists, speech therapists, endocrinologists, and rehabilitation specialists may be beneficial. Overall, individualized perioperative management may help reduce postoperative morbidity and improve quality of life. In conclusion, post-thyroidectomy dysphagia represents a common but frequently underestimated postoperative complication. Most patients experience transient swallowing difficulties that gradually improve within the first few postoperative months. The pathophysiology appears to be multifactorial, involving neural, muscular, mechanical, inflammatory, and psychological mechanisms. Although the majority of patients recover, persistent symptoms may substantially impair quality of life and postoperative satisfaction. Current evidence remains limited by methodological heterogeneity and lack of standardized swallowing assessment protocols. Future prospective uh, multi-center studies with objective outcome measures and longer follow-up are necessary to improve our understanding and management of this condition. To summarize, swallowing dysfunction after thyroidectomy is a relatively common postoperative symptom, although in most patients it remains temporary and self-limited. Importantly, dysphagia may occur even in the absence of obvious recurrent laryngeal nerve injury, supporting the multifactorial nature of this condition. Appropriate preoperative counseling and postoperative follow-up are essential for improving patient satisfaction and quality of life. In patients with persistent or severe symptoms, objective swallowing assessment may provide valuable diagnostic information. Finally, additional standardized prospective studies are necessary in order to better define the mechanism, risk factor, and optimal management strategies for post-thyroidectomy dysphagia. Thank you very much for your attention.
Okay, so a very good evening to one and all present here. I'm Dr. Ankita Ghosh, a specialist advisor at the Royal College of Surgeons, England, and I'm doing my post-graduation in oral medicine and radiology at Guru Nanak Institute of Dental Sciences and Research, I'm here today to talk with you all about clinical and histopathological insights from a case series of oral malignancies in habitual tobacco users attending a dental institute in eastern India. I will be talking about the interplay of tobacco carcinogenesis, how BMR affects the chances of having cancer, immunomodulation, pharmacological ascorbate, and precision radiotherapy. Next slide, please. Okay, so starting with part one, we will be talking about squamous cell carcinoma, OSMF, histopathology, and how common cancer is in Eastern India. Next slide, please. So this is a gist of the abstract. Here you can see the background wherein I have taken a few cases of oral malignancies in Eastern India, the ones that came to my institution. We have an objective here to present four clinically diverse oral malignancy cases that have arrived at my institution, highlighting the diagnostic challenges, the habit profiles, and histopathological correlation. Now, methods, it's a retrospective institutional case series. Results, we have seen that in tobacco users, ulceroproliferative lesions are more, and biopsy is essential for confirming SCC. In conclusion, what we will be talking here about is how important early diagnosis is, about histopathological confirmation, about habit history, and about the importance of biopsy. Next slide, please. Okay, so this is an epidemiological backdrop on oral cancer. You can see on the slide that it's the sixth most common cancer in India, and also the ratio of male to female is 5:1. So males are most importantly affected. A late presentation mostly happens when a patient comes to you in stage 3 to 4, and that's very common because people tend to neglect their symptoms. Tobacco etiology, it has been commonly seen that tobacco users happen to form cancer. OSMF prevalence, it has been shown that OSMF is a pre-malignant lesion and it leads to cancer. And there's a screening gap because people tend to neglect their health, and by the time they come to the OPD, the cancer has spread and they are at a later stage. Next slide, please. Okay, so talking about background and rationale. So, how tobacco leads to carcinogenesis. So, what happens is we have nitrosamines in tobacco. So, it leads to DNA alkali, alkylation, and it leads to P53 mutation. So, this is this leads to chromosomal aberration, adduction, and leading to cancer. In Eastern India, we have seen a high prevalence of tobacco users and people having cancer. Histopathological validation is very important. If a lesion remains after 2 weeks, we have to go for biopsy to confirm whether the case is malignant or not. So, study rationale. Here we will be characterizing a cohort of four studies, and we will be talking about how tobacco causes cancer, about how early diagnosis is important. Next slide, please. Okay, so tobacco and oral carcinogenesis. The flowchart here depicts how tobacco can lead to cancer. So on tobacco exposure, there is carcinogen activation leading to DNA damage. The oncogenes are activated, leading to dysplasia. So key risks that amplify carcinogenesis, one is duration is important, the frequency is important, how often you're having tobacco, the type is important, and also comorbidities. If you have diabetes, if you have an immunocompromised condition. Next slide, please. Next slide, please. Yes, thank you. Study design and methods. So the study type is a retrospective study. The setting is my dental institution. The sample comprises of 4 habitual tobacco users, and the age range lies within 29 to 58 years, and all of them are male. Duration of habit spans from 8 to 40 years. On clinical examination, both intraoral and extraoral, the site of the lesion has been determined, the habit history has been taken, radiographic imaging has been done, and incisional biopsy has been done. been done to confirm OSCC. Next slide, please. So this is the case cohort overview. You can see 4 cases. Let's start with the first one. So a 54-year-old male patient arrived at the OPD. He has been having coini since the last 30 years, around 8 to 10 per day. And the site of his lesion was upper alveolar mucosa, and the lesion was ulceroproliferative. We diagnosed it to be suspected malignancy. The second case was that of a 58-year-old male patient with a history of pan consumption since the last 30 to 40 years. He had a lesion in the left buccal mucosa, and there was verrucous ulceroproliferative growth, and we suspected it to be verrucous CA. The third case was that of a 51-year-old male patient who has been consuming pan since the last 15 to 20 years and had a lesion on his right buccal mucosa. It showed a proliferative growth, and the patient also had OSMF. So we suspected it to be malignancy, and we can here see that how OSMF can actually precipitate as malignancy. The last case, the youngest of all, he's 29 years old. He was having both gutka and smoking. So we have synergistic habit history here since the last 8 years, the shortest duration of all the cases. He had a lesion in his left buccal mucosa. He went for a biopsy, and it was a confirmed case of well-differentiated squamous cell carcinoma. Next slide, please. I will be talking about the fourth case, that is the youngest patient here. You can see the picture on the top right corner on your phone on your screen. So the chief complaint was that he was having a non-healing lesion, which was painful. Upon clinical examination, we saw an endophytic lesion, and the biopsy confirmed it to be a case of well-differentiated squamous cell carcinoma. So the prognosis was not too good. It's in the last stage. We did the TNM staging, and the habit history has been taken. So from here, what is the key takeaway point? It is the youngest case in the series, and it has been seen that dual habit synergy produces the SCC at a markedly younger stage, at a younger age. Next slide, please. So histopathological classification and WHO grading, we have 4 grades. One is well-differentiated squamous cell carcinoma. The second one is moderately differentiated squamous cell carcinoma. The third one is poorly differentiated squamous cell carcinoma. And the last one is proliferative verrucous leukoplakia. Next slide, please. So TNM staging and oral squamous cell carcinoma. So according to the size of the tumor, we have T1, T2, T3, T4. According to the lymph node involvement, we have N staging. And according to metastasis, we have M staging. So you can see in red the staging of the young patient that we had in the outpatient department. Next slide, please. So this is a bar chart showing how case 2, the PAN patient had the maximum years of habit history. However, the case 4 in red had the least duration of habit history, but a confirmed case of well-differentiated squamous cell carcinoma. And also seeing the trend, it has been seen that all of them have developed SCC in buccal mucosa. So that's a very prevalent site. The age, you can see most of them are in the older age group. And it has also been seen that OSMF comorbidity has been found out from the cases. Next slide, please. So the diagnostic challenges that we face every day at the OPD. One is late symptom recognition. Most of them realize of their symptoms really late. Second is OSMF-induced trismus, due to which there is decreased mouth opening and we can't really see the lesion very well. Number 3 is lesion morphology overlap. So generally, it's difficult for us to clinically distinguish unless biopsy is done. Low health literacy, people are not aware about their oral health. Comorbidity complexity, generally there is a comorbid condition like hyperglycemia that is creating problems, and it is aggravating the condition. And single biopsy limitation. So people tend to neglect doing a biopsy, and hence a final diagnosis is often not received. It's not often not achieved. Next slide, please. So clinical implications and screening recommendations. One is structured habit history needs to be taken. Mandatory biopsy protocol needs to be followed. Tobacco cessation integration needs to be done. Systematic intraoral screening needs to be done. OSMF surveillance needs to be done. And institutional data collection needs to be done to see how many cases we are getting each day that are malignant cases. Next slide, please. I will be concluding the first part with the following points. Number one, you can see that tobacco habit duration does have an effect with causing cancer. However, we see that a younger patient who shows synergistic habit of two habit components, he has developed a confirmed case of well-differentiated squamous cell carcinoma. We have seen that buccal mucosa is the predominant site. We have seen that OSMF is a pre-malignant condition. We have seen that routine biopsy is very important in order to come to a final diagnosis. And we have also seen that institutional case series data should be taken to create awareness. Next slide, please. Now we will be coming to the theory bit of oral squamous cell carcinoma cancer. So here we will be talking about the interplay of basal metabolic rate. We will be talking about immunomodulatory networks. We will be talking about physiological ascorbate in advanced head neck squamous cell carcinoma. Next slide, please. So this is the global burden. It paints the picture of how cancer affects and how dreadful the condition is in the entire world today. So we have two subtypes. One is HPV negative and one is HPV positive when it comes to head neck squamous cell carcinoma classification on the basis of etiology. Next slide, please. Next slide, please. So BMR, basal metabolic rate, it is a prognostic marker in head neck squamous cell carcinoma. What happens is that when your metabolic rate, your BMR falls, there is a risk of sarcopenia, there is immune suppression, there is poor overall survival, and there is nutritional stratification. Next slide, please. So here I will be talking about metabolic reprogramming in head neck squamous cell carcinoma. We'll be talking about two important effects. One is the Warburg effect and the other one is lipid dysregulation. So what happens in the Warburg effect? The cancer cells, they exploit the aerobic glycolysis to generate an acidic environment. There is suppression of the immune cells, and there is increase in inhibitory TREG proliferation. It creates an immune excluded tumor niche, promoting angiogenesis and invasion through lactate signaling. Now, lipid dysregulation, what happens is that it basically increases the resistance to radiotherapy. So the cancer cells become so immune to radiotherapy that they don't tend to get destroyed in spite of giving radiotherapy. Next slide, please. Now we'll be talking about Siglec. So what happens is that it is a novel checkpoint driving immune resistance in cancer. So what happens in the kinin pathway? Tryptophan metabolism is hijacked and diverted to kyurenin, which penetrates the immune cells and triggers something known as the AHR. So what happens is that there is overexpression of Siglec and there is therapeutic targeting. So what happens is that Siglec generally masks the cancer cells. In simple words, what happens is that the Siglec masks the cancer cells and the immune cells cannot identify the cells to be cancerous if they are. Next slide, please. So precision radiotherapy modalities. Number one is intensity modulated radiation therapy. Number two is proton beam therapy. Number three is stereotactic body radiation therapy. Number four is spatially fractionated radiation therapy. Next slide, please. So how radiation therapy can act as an in situ vaccine. So what happens is that when you give radiation therapy, there is DNA damage. Then there is release of damp and there is cross presentation leading to abscopal effect. So sometimes what happens is that if you have developed cancer, and you're getting immunotherapy, there are less chances of metastasis because the body gets immune to creating cancer anymore. Next slide, please. So how vitamin C can help in fighting cancer? Vitamin C is very important and it helps in building your immune system. The 4 points here actually show how it can help in treating cancer. Number one, there is reduced oxygen species generation, there is epigenetic restoration, there is therapeutic synergy and metabolic collapse. So high dose IV vitamin C is actually very important and it has selective anti-tumor effect against cancer. Next slide, please. Systemic inflammation. So the neutrophil and lymphocyte marker, they actually help in determining whether you have cancer or not. Here I have put down 3 levels of NLR that serve to tell you what stage of cancer you are in. Next slide, please. So the horizon of vaccination in HNSCC, one is HPV vaccination that is preventive and it has a 90% coverage goal. The next one is therapeutic vaccination. So it has a response rate of about 59%. And the last one is mRNA personalization. So it has about a 34% output rate. Next slide, please. So the cancer treatment is not just involving oncologists, but it is actually a multidisciplinary networking that cures cancer. So we need the following things in curing cancer. Number one is BMR optimization. Number two is immunomodulation. Number three is neoantigen vaccination. Number four is pharmacological ascorbate. And number five is precision radiotherapy. So we need these components, that is from palliative management to long-term cure in advanced head neck squamous cell carcinoma. Next slide, please. So this is the cohort that I had presented before. It is just showing you about the cases that we had, about how the young patient showed a case of confirmed cancer, about how synergistic habit history plays a huge role in creating cancer. So it's just a summary chart. Next slide, please. Next slide, please. So these are my grand conclusions. Number one, tobacco and dual habit synergy. So we had a live example of how habit synergy plays a huge role in creating cancer. We have novel immunosuppressive axis. Here we will be talking about Siglic that I've mentioned before. Pharmacological ascorbate, how vitamin C can help us in fighting cancer in both prevention and treatment. So I think vitamin C plays a huge role today in controlling cancer. Then we have metabolic reprogramming, where we already spoke about the Warburg effect and the FASN-driven lipogenesis. Then we have precision radiotherapy and abscopal effect. And the last one we will be talking about NLR, HPV vaccination and neoantigen platforms. So I would like to conclude by telling you that cancer is a disease of time. So if we can catch hold of the monstrous situation at its earliest, then I'm sure we can completely eradicate it and exclude it from our system. And together we can totally find an absolute and definitive cure for cancer, so that the fear of cancer is out from the minds of everybody here today. Next slide, please. Thank you so much for giving me a patient hearing. You can send in questions if you have on drankitaghosh@gmail.com.
In this presentation, I will discuss the complex and evolving topic of multiple primary malignancies in head and neck cancer. The presentation focuses on the molecular mechanism, etiological factors, diagnostic challenges, and emerging therapeutic strategies associated with synchronous and metachronous head and neck tumors. Special emphasis will be given to field cancerization, tumor heterogeneity, and the role of precision oncology in modern management. The development of multiple primary malignancies in patients with head and neck cancer is not a rare clinical event. In recent years, the incidence of multiple head and neck cancer has increased significantly due to improved diagnostic techniques, better surveillance strategies, advances in treatment, and a longer patient survival. The literature suggests that the risk of developing a second primary malignancy increase by approximately 3% annually in patients who survive head and neck cancer. And this tumor may appear either synchronously, meaning simultaneously or within a short time interval, or metachronically occurring months or years after the initial tumor. Despite therapeutic advances, patients with multiple primary tumors frequently demonstrate poor prognosis, increased recurrence rates, and reduced overall survival. Multiple primary malignancies are generally uh, classified as synchronous or metachronous tumors. Synchronous tumors are diagnosed either simultaneously or within 6 months of the initial primary malignancy. In contrast, metachronous tumors develop more than 6 months after the diagnosis of the first cancer. The distinction between recurrence, metastasis, and true second primary tumor is often challenging and has important therapeutic and prognostic implications. Several diagnostic criteria have been proposed, including histopathological differences, anatomical separation between lesions, and inclusion of metastatic spread. Modern molecular profiling techniques are increasingly used to improve diagnostic accuracy and clarify clonal relationships between tumors. The concept of field cancerization is fundamental in understanding the development of multiple primary malignancies in head and neck cancer. Long-term exposure to carcinogens such as tobacco, alcohol, and oncogenic viruses like HPV induces when-spread molecular alteration throughout the upper digestive tract. Although the mucosa may appear clinically normal, genetically altered epithelial fields may already exist. These premalignant fields accumulate genetic and epigenetic abnormalities, promoting clonal expansion and progressive molecular instability. As a result, multiple independent tumors may develop either simultaneously or sequentially within the same anatomical region. Field cancerization, therefore, represents one of the main biological explanation for synchronous and metachronous head and neck cancer. The molecular pathogenesis of multiple primary head and neck malignancy is highly complex and involves the accumulation of numerous genetic and epigenetic alterations. Among the most frequently affected genes are TP53, CDKN2A, and NOTCH1, which regulate cell cycle control, apoptosis, proliferation, and differentiation. Epigenetic dysregulation, including DNA methylation and histone modification, further contributes to malignant transformation and tumor progression. In addition, epithelial to mesenchymal transition, also known as ENT, promotes tumor invasion, metastatic potential, and therapeutic resistance. Cancer stem cells are also believed to play a critical role in tumor recurrence and clonal evolution. Overall, molecular heterogeneity represents one of the major challenges in precision oncology and individualized treatment planning. Clonal evolution and tumor heterogeneity play a major role in the development of multiple primary malignancies in head and neck cancer. During tumor progression, genetically altered cells accumulate additional mutation over time, resulting in the emergence of distinct tumor subclones. This process creates significant intratumoral heterogeneity with different cellular population demonstrating variable biological behavior and therapeutic sensitivity. Some lesions may share common ancestral mutation, while others evolve independently through separate molecular pathways. This mechanism contributes to treatment resistance, disease progression, and the development of synchronous or metachronous tumors. Understanding clonal dynamics is therefore essential for molecular classification, a personalized therapy, and precision oncology approaches. One of the greatest clinical challenges in head and neck oncology is differentiating tumor recurrence from a true second primary malignancy. Conventional histopathological evaluation is often insufficient, particularly when tumors demonstrate similar morphology. Modern molecular profiling techniques, including next-generation sequencing, can help identify shared or distinctive mutational patterns between lesions. In recent years, liquid biopsy and circulating tumor DNA analysis have emerged as promising, minimally invasive diagnostic tools. Advanced imaging modalities, particularly PET-CT, also play a crucial role in detecting occult lesions, evaluating tumor extent, and improving surveillance strategies. Accurate diagnosis is essential because it directly influences prognosis, treatment selection, and long-term patient management. The management of multiple primary malignancies in head and neck cancer requires a highly individualized and multidisciplinary approach. Treatment decisions depend on tumor location, stage, molecular characteristics, prior therapies, and the patient's overall functional status. Surgical resection remains a cornerstone of treatment for resectable tumors and may provide optimal local control. Radiotherapy and concurrent chemotherapy also play a major role, particularly in locally advanced disease or organ preservation protocols. In recurrent or metastatic setting, systemic therapies, including chemotherapy, targeting therapy, and immunotherapy, become increasingly important. A major challenge is balancing oncological control with quality of life, speed, swallowing, and long-term functional outcomes. Recent advances in immunotherapy have significantly changed the therapeutic landscape of head and neck cancer. Immune checkpoint inhibitors targeting the PD-1 pathway, such as pembrolizumab and nivolumab, have demonstrated improved survival in recurrent and metastatic disease. Targeting therapies also remain important, particularly cetuximab, which inhibits the epidermal growth factor receptor or EGFR pathway. The identification of predictive biomarkers is becoming increasingly relevant for individual treatment selection and response prediction. The current research is also focusing on a combination treatment strategy involving immunotherapy, radiotherapy, chemotherapy, and molecular targeting agents. These approaches may further improve clinical outcomes while reducing unnecessary toxicity. Patients with multiple primary head and neck malignancies require intensive and long-term surveillance strategies. The risk of recurrence and the development of additional metastatic tumor remains significantly elevated even years after the initial diagnosis. Advanced imaging modalities, including PET-CT and MRI, play a crucial role in early tumor detection and disease monitoring. Endoscopic evaluation is also essential, particularly in high-risk patients with field cancerization of the upper aerodigestive tract. Emerging molecular techniques such as liquid biopsy and circulating tumor DNA analysis may further improve early diagnosis and real-time monitoring. Um, Ultimately, surveillance protocols should be individualized according to tumor biology, previous treatment exposure, and patient-specific risk factor. Precision oncology is rapidly transforming the management of head and neck cancer. Comprehensive molecular profiling and genomic sequencing now allow a more individualized understanding of tumor biology and therapeutic response. These technologies help identify actionable mutation and support more personalized treatment strategies. Artificial intelligence and machine learning algorithms are also emerging as valuable tools in imaging analysis risk prediction, and treatment planning. At the same time, liquid biopsy and circulating tumor DNA analysis may enable real-time monitoring of tumor evolution and therapeutic resistance. Future research is expected to integrate molecular diagnostic, targeting therapies, immunotherapy, and artificial intelligence into highly personalized oncological care pathways. The ultimate goal is to improve the survival outcomes while minimizing treatment-related toxicity and preserving quality of life. Multiple primary malignancies represent a major clinical and oncological challenge in head and neck cancer. Their development is strongly associated with field cancerization, genetic instability, and progressive molecular heterogeneity. Early diagnosis and accurate differentiation between recurrence and true second primary tumors remain essential for optimal management. Long-term surveillance and multidisciplinary collaboration are critical in improving patient outcomes and quality of life. Recent advances in molecular oncology, immunotherapy, liquid biopsy, and precision uh, medicine are rapidly changing the future of head and neck cancer care. Further research is still needed to optimize individualized therapeutic strategies and improve long-term survival. In summary, multiple primary malignancies represent a complex and increasingly important challenge in head and neck oncology. Their development is driven by field cancerization, genetic instability, and progressive molecular heterogeneity. Accurate diagnosis, early detection, and long-term surveillance are critical for improving patient outcomes. Modern molecular profiling techniques and precision oncology approaches are increasingly shaping individuals' treatment strategies. Finally, successful management requires close multidisciplinary collaboration in order to optimize survival, functional outcomes, and the quality of life. Thank you very much for your attention. And multidisciplinary approach. Treatment decisions depend on tumor location, stage, molecular characteristics, prior therapies, and the patient's overall functional status. Surgical resection remains a cornerstone of treatment for resectable tumors and may provide optimal local control. Radiotherapy and concurrent chemotherapy also play a major role, particularly in locally advanced disease or organ preservation protocols. In recurrent or metastatic settings, systemic therapies, including chemotherapy, targeting therapy, and immunotherapy, become increasingly important. A major challenge is balancing oncological control with quality of life, speed, swallowing, and long-term functional outcomes. Recent advances in immunotherapy have significantly changed the therapeutic landscape of head and neck cancer. Immune checkpoint inhibitors targeting the PD-1 pathways such as pembrolizumab and nivolumab have demonstrated improved survival in recurrent and metastatic disease. Targeting therapies also remain important, particularly cetuximab, which inhibits the epidermal growth factor receptor or EGFR pathway. The identification of predictive biomarkers is becoming increasingly relevant for individual treatment selection and response prediction. The current research is also focusing on a combination treatment strategy involving immunotherapy, radiotherapy, chemotherapy, and molecular targeting agents. These approaches may further improve clinical outcomes while reducing unnecessary toxicity. Patients with multiple primary head and neck malignancies require intensive and long-term surveillance strategies. The risk of recurrence and the development of additional metastatic tumor remains significantly elevated even years after the initial diagnosis. Advanced imaging modalities, including PET-CT and MRI, play a crucial role in early tumor detection and disease monitoring. Endoscopic evaluation is also essential, particularly in high-risk patients with field cancerization of the upper aerodigestive tract. Emerging molecular techniques such as liquid biopsy and circulating tumor DNA analysis may further improve early diagnosis and real-time monitoring. Um, Ultimately, surveillance protocols should be individualized according to tumor biology, previous treatment exposure, and patient-specific risk factor. Precision oncology is rapidly transforming the management of head and neck cancer. Comprehensive molecular profiling and genomic sequencing now allow more individualized understanding of tumor biology and therapeutic response. These technologies help identify actionable mutation and support more personalized treatment strategies. Artificial intelligence and machine learning algorithms are also emerging as valuable tools in imaging analysis, risk prediction, and treatment planning. At the same time, liquid biopsy and circulating tumor DNA analysis may enable real-time monitoring of tumor evolution and therapeutic resistance. Future research is expected to integrate molecular diagnostic, targeting therapies, immunotherapy, and artificial intelligence into highly personalized oncological care pathways. The ultimate goal is to improve the survival outcomes while minimizing treatment-related toxicity and preserving quality of life. Multiple primary malignancies represent a major clinical and oncological challenge in head and neck cancer. Their development is strongly associated with field cancerization, genetic instability, and progressive molecular heterogeneity. Early diagnosis and accurate differentiation between recurrence and true second primary tumors remain essential for optimal management. Long-term surveillance and multidisciplinary collaboration are critical in improving patient outcomes and quality of life. Recent advances in molecular oncology, immunotherapy, liquid biopsy, and precision uh, medicine are rapidly changing the future of head and neck cancer care. Further research is still needed to optimize individualized therapeutic strategies and improve long-term survival. In summary, multiple primary malignancies represent a complex and increasingly important challenge in head and neck oncology. Their development is driven by field cancerization, genetic instability, and progressive molecular heterogeneity. Accurate diagnosis, early detection, and long-term surveillance are critical for improving patient outcomes. Modern molecular profiling techniques and precision oncology approaches are increasingly shaping individuals' treatment strategies. Finally, successful management requires close multidisciplinary collaboration in order to optimize survival, functional outcomes, and the quality of life. Thank you very much for your attention.
We will share the email ID of Dr. Eleni Litso in the chat box. So if anyone is having any queries, you can contact her through email. Moving on to the next presentation. The next presenter will be Dr. Shaili Priyamvada from Rama University, India, on the title A Rare Case of Spontaneous External Jugular Vein Pseudoaneurysm. Dr. Shaili?
Yeah, I'm here. Thank you. Thank you for that. Good evening, everyone. I would just share my screen. Is my presentation visible?
No, doctor.
No?
No.
Okay, please give me a minute.
Yes.
It's visible now, I believe.
Yes.
Okay. Good evening, everyone. I am Dr. Shirley from New Delhi, India. We came across a rare case, extremely rare case of venous pseudoaneurysm. It was a 40 years old
Dr.
female.
Shaili, sorry for the distance.
Yes.
It would be appreciable if you can switch on your camera. We can't able to see you.
Okay, sure. Yeah, I will. Yes. I need a minute. Good evening, everyone.
But we can see your slides now. So, yes, perfect.
Okay, can you see my slides? All
Yes,
right.
yes, yes.
So, yeah. So we came across a 40 years old female. Initially, we thought that it's a case of laryngosele, given the signs, but we investigated and we found out that it's a rare case of spontaneous external jugular vein pseudoaneurysm. So, what is an aneurysm? An aneurysm is defined as the dilatation of all three layers of vessel wall, that is tunica adventitia, tunica media, and intima. Whereas a pseudoaneurysm is a tear through just the outer layers of the venous wall. And if there is accumulation of blood and thrombus, and there is thrombus formation in some cases, which was present in our case. Arterial or venous aneurysms and pseudoaneurysms are extremely rare entities. Arterial aneurysms are a little more common as compared to venous ones, as venous system has low pressure blood flow system. Exact incidence is not known. Only few cases have been reported to the literature. True or pseudoaneurysm, they are usually formed after iatrogenic trauma. Spontaneous pseudoaneurysms are extremely rare. Only few cases have been reported. Around 77% of the venous aneurysms are found in lower extremities. We came across a case of spontaneous pseudoaneurysm arising from right jugular vein and reported it to the literature. Our case was taken up surgically, details of which are coming up, and with positive outcomes. So this is the female, 40 years old female, who presented to us with right cervical swelling, which was lying in the middle third of sternocleidomastoid muscle, and it was present for 1.5 years. It was insidious in onset, painless in nature, gradually increased in size over this period. There was increase in size of swelling when the patient is blowing or doing Valsalva, and there was reduction in size if the swelling was pressed over. There was no tingling or numbness. There was no history of trauma to neck or any previous neck surgery. Patient did not have any difficulty in breathing or swallowing. There was no history of any pain, dysphagia, or change in voice. On examination, patient had 4 by 3 centimeter size swelling present in lateral cervical region situated over middle third of sternocleidomastoid muscle. The swelling was soft, compressible, and increased in size on doing Valsalva. It was non-pulsatile, immobile in nature, did not change in size with respiration or swallowing. There was no petechiae, ecchymosis, or any signs of inflammation present over the overlying skin. The first clinical diagnosis which was made was of laryngocele. Then we investigated. Routine blood work was within normal limits. The first investigation that we did is ultrasound neck, after which was immediately followed, because of the finding, it was followed by color Doppler. So these are the ultrasound findings. Left one is of plain ultrasound neck, and the right one is with color Doppler, which showed 4 by 4 centimeter size swelling, which was arising, which was anechoic on gray scale and arising from right, closely abutting right external jugular vein. It was situated below the subcutaneous layer of the neck and over the sternocleidomastoid muscle. It was connected to external jugular vein medially. USG Doppler showed internal to and fro. This is the swelling which was present. This is the external jugular vein, and it showed to and fro pattern, which is highly typical for pseudoaneurysms. And this was the floating thrombus inside this patient's pseudoaneurysm, which was typical for. That's how the radiologist, we first thought that it's a case of pseudoaneurysm. Next, CECT was done to confirm the diagnosis. It showed enhancing lesion of size 11.8, 23.4, and 30 mm, situated closely abutting the right external jugular vein. This is the cystic mass, and this is the thrombus inside. This is closely abutting the right external jugular vein here, and this was overlying the sternocleidomastoid muscle, and the planes around this swelling were well defined. There was no infiltration or encroachment to surrounding structures. So case was discussed amongst otolaryngologists and surgical option was given to the patient. Written, informed, high-risk consent was taken after explaining the rarity of the disease. All the possible complications, such as rupture of the aneurysm, pulmonary embolism, and death on the table, was explained to the patient. Consent for publishing the details of the case was also obtained from the patient. Pre-anesthetic checkup and clearance was taken. Blood pints were arranged, and patient was taken up for surgery under general anesthesia. So these are the markings. Linear incision about 6 cm was given over the mass on the right side. Skin and subcutaneous tissue separated out. Pseudoaneurysm arising from right jugular vein is seen here. So this is the pseudoaneurysm. This is the external jugular vein medially, and there was a tributary. This is the tributary to this aneurysm, which we found intraoperatively. So in the superficial layer of deep cervical fascia and lying over the sternocleidomastoid muscle, dissection progressed to delineate the upper end, the lower end of the pseudoaneurysm, which was tied, and the tributary, which was coming medially, was also delineated and tied down. The upper, lower ends and tributaries were ligated and cut. Mass taken out for histopathic examination. Wound was closed in layer with 30 vicryl, and this is the cut aneurysm. Histopath findings were consistent with pseudoaneurysm. It showed outer layers of the venous wall with centrally situated thrombus. Patient was doing fine perioperatively. She received antibiotics and supportives, and she was made ambulatory on the very next day of the surgery. So, about the aneurysms and pseudoaneurysm, ultrasound scan is the most useful first investigation in the diagnosis to differentiate it from other entities such as cervical lymph nodes, benign cystic lesions in the neck, thyroid swelling, neck abscesses, cystic hygroma. CT scan or MRI helps further substantiate the diagnosis and to confirm the diagnosis. Doppler ultrasound is the gold standard investigation for such cases. This to and fro flow confirms that patient has, and that is the typical for aneurysms and pseudoaneurysms. Surgical intervention is indicated only if patient has cosmetic concerns, any complications such as thrombus formation, which was present in our case, thrombophlebitis, or thromboembolism. Our patient was managed surgically with positive outcomes. We concluded that pseudoaneurysms, even though they are rare, they should be considered as a differential diagnosis if there are signs, symptoms, and signs, they point towards that aneurysm. So this is the link to the article that we published in July 2025 in Indian Journal of Otolaryngology and Head and Neck Surgery. Thank you for your patient listening.
I am Dr. Hamna Rashid, working as a postgraduate resident in Pakistan Institute of Medical Sciences, Islamabad. Today, I'll be presenting a highly aggressive and diagnostically challenging case managed at our center. And this case report was published a couple of months back in Curious, and we titled it as Unmasking the Silent Invader, a rare case report of oral mucosal malignant melanoma with rapid multisystem dissemination. To contextualize this case, a primary oral mucosal melanoma is an exceedingly rare malignancy representing less than 2% of all the melanoma diagnoses. Unlike cutaneous melanomas, it has no relationship with the ultraviolet radiation exposure, and it exhibits an entirely distinct genetic profile. The clinical challenge peaks with the amelanotic variant, which makes up less than 1% of the cases. Because these lesions lack classic melanin pigmentation, they easily masquerade as pyogenic granulomas, standard carcinomas, or mesenchymal sarcomas, leading to critical diagnostic delays. All right. So our patient was a 47 years old male resident of Punjab, Pakistan, who presented to our ENT department with a 9-month history of a rapidly expanding non-healing oral lesion. It originally started on the hard palate and it progressively spread to involve the upper gingiva. He experienced local pain, worsening contact bleeding, localized loosening of teeth, and significant structural weight loss, apparently distinctly cachectic on arrival. So these are the images of the patient. On examination, we noted a massive 5 into 6 centimeter ulceroexophytic tumor extended from the left upper first molar across the right lateral incisor. You all can see in these images. Structurally, the mucosa was predominantly pinkish pale, ulcerated, and necrotic. Grossly, it lacked the dark pigmentation typical of melanoma, showing only trace focal pigmentation upon meticulous close inspection. Furthermore, evaluation of neck revealed advanced bilateral nodal disease with a prominent hard fixed 4 into 3 centimeter mass at the left level 1B alongside smaller fixed nodes bilaterally. So next, okay. Reviewing his timeline, the patient had undergone an initial incisional biopsy at a dental facility in March 2025 when the lesion was limited to the palate only. The purely morphological assessment was highly misleading, demonstrating nested, elongated, malignant spindle cells that thoroughly mimicked a mesenchymal sarcoma. However, the immunohistochemical staining was pivotal. The tumor demonstrated intense positivity for S100, SOX10, and Milan A, while remaining strictly negative for cytokeratin, establishing a definitive diagnosis of amelanotic melanoma. These are the CT scan images. We can all see that CT scan, contrast-enhanced CT scan head and neck images in axial view, showing enhancing mucosal thickening in the left upper gingival lesion, as shown by the red arrows, and also my cursor is pointing towards the moon. Following the diagnosis, the patient was referred to medical oncology and completed 3 cycles of immunotherapy by pembrolizumab by October 2025. Unfortunately, the tumor exhibited absolute primary resistance. Follow-up imaging revealed aggressive local progression, as shown in these post-immunotherapy CT scan images, characterized by extensive destruction of the maxillary bone and infiltration deeper into the gingivo-buccal spaces, alongside central liquefactive necrosis of the cervical lymph nodes. A repeat biopsy confirmed the diagnosis, showing a transition to highly pleomorphic epithelioid and spindle cell sheets embedded within a dense desmoplastic stroma, which were done post-immunotherapy, and they indicated interval progression of the disease along with the nodal involvement. These are the H&E stained photomicrographs, which are at different magnifications. First one is at 4x, then 10x, and then 40x. And we can clearly see in these photomicrographs of histology and desmoplastic stroma, characteristic of mucosal malignant melanoma. So the patient was all right. Given the extensive local disease, the patient was admitted to our ward to undergo a salvage maxillectomy and bilateral neck dissection. However, during his progressive preoperative workup, he developed rapidly progressive paresis of the left upper limb, with motor strength dropping to 3/5 within 10 days. An urgent contrast-enhanced MRI brain was obtained, revealing 2 large heterogeneous intraaxial metastatic lesions surrounded by severe vasogenic edema, confirming rapid systemic hematogenous dissemination. So these are the contrast-enhanced MRI images, and we can see that space-occupying lesions on the bilateral sides of the cerebral hemispheres. This case was immediately then escalated to a multidisciplinary tumor board in the light of active intracranial metastasis, an advanced structural invasion, and documented failure of checkpoint inhibition. The disease was deemed unresectable. The management goal was shifted to palliative external beam radiotherapy and optimized symptom care. In conclusion, this case highlights a critical clinical lesson. That is, the absence of pigmentation should never eliminate melanoma from your differential diagnosis. Amelanotic oral mucosal melanoma is an aggressive silent invader. Early deep biopsy, mandatory reliance on immunohistochemistry, and immediate multispecialty intervention represent our only opportunities to alter the poor prognosis of this lethal disease. I thank you all, and I am open.
My name is Zahra Valipour. I'm an assistant professor of otorhinolaryngology at Mashhad University of Medical Sciences from Iraq. Today, I would like to present our experience with evaluating the efficacy of endoscopic medialization laryngoplasty with autologous nasal septal cartilage graft. First, I will briefly review the background and rationale of the study. Then I explain the surgical technique and study design. After that, we have outcomes of voice and laryngoscopic finding, discussion, conclusion, and finally, we have a short surgical video from the procedure. Unilateral vocal cord paralysis results from recurrent laryngeal nerve or vocal nerve dysfunction and may severely impair phonation, airway protection, and swallowing. The most common etiologies, including thyroidectomy, skull-base surgery, thoracic surgery, malignancy, viral neuropathy, and idiopathic paralysis. And it may lead to incomplete glottic closure. So the patients have experienced breath dysphonia, reduced maximal phonation time, impaired cough reflex, recurrent aspirations, and more psychological problems. Several treatment modalities have been proposed, including injection laryngoplasty, thyroplasty, arytenoid abduction, and re-innervation procedures. An ideal medialization material should be biocompatible, stable, durable, readily available, and associated with minimal foreign body reaction. Traditional medialization laryngoplasty via external thyroplasty is effective but associated with cervical incision, implant-related complications, and cosmetic concerns. Autologous cartilage graft potentially satisfy this criteria while eliminating the risk of implant extrusion or rejection. So, endoscopic medialization laryngoplasty using autologous nasal septal cartilage may provide a minimally invasive or compatible and durable alternative. Our study is prospective single-arm clinical trial conducted at Mashhad University of Medical Sciences in Kuala Hospital. We have 18 patients with symptomatic unilateral vocal cord paralysis refractory to conservative management, and we have some exclusion criteria, including patient unwillingness to participate, saddle nose deformity, and bilateral vocal paralysis, history of septoplasty, limitation in cervical extension, and some various comorbidities, including uncontrolled head and neck malignancy, external laryngeal trauma, laryngeal neoplasm, severe laryngeal stenosis, central nervous system disorder, and severe cardiopulmonary disorder. In method, we evaluate laryngoscopic finding, including glottic gap configuration, vocal port position, mucosal wave characteristic, and then acoustic parameter, including fundamental frequency, jitter, shimmer, harmonic to noise ratio. And then we evaluate auditory perceptual using the GRBAS scale. We also followed every patient at 2 weeks, 2 months, and 6 months after surgery, and finally, we have analyzed statically by repeated measures. Now I will briefly explain the surgical techniques. And the procedure was performed through a transoral endoscopic approach under general anesthesia. At first, we harvested and scalped autologous nasal septal cartilage. Then we have a step one at the micro laryngoscopy, and we measured the anterior commissure to vocal process distance. After that, we inject the lidocaine and epinephrine before incision, and then we incise lateral laticy, and we have superior cordotomy and lateral microflap incision. As you can see in this picture, the incision is lateral to the true vocal cord, and therefore the lamina propria is not damaged. We dissect the muscular layer and insert the cartilage graft within the muscle. Then we create a pocket in thyroaryngologic vocalis complex. After that, we insert the first cartilage graft. According to the obtained size, a graft strip equal to the measured length and width of 2 to 3 millimeters. As you can see in this picture, the position of first graft, you can see. After that, additional layered cartilage insertion may be needed. Other strips with shorter lengths and similar widths were placed separately in the pocket from anterior to the posterior medial of the first strip to achieve medialization based on the sagittal and vertical planes of vocal cord. As you can see in this picture, final graft medialization achieved. Then we close the incision while schizo we create suture. Okay. Regarding patient characteristics, the mean age was approximately 47 years, and most patients were female. And mean paralysis duration is about 86 months. Now let us move to the result. Most of the etiology of unilateral vocal paralysis in our study is thyroid neoplasm and the surgery because of that. After that, scalp surgery, post-viral neuropathy, idiopathic paralysis, traumatic injury, and one of our patients was due to progressive tuberculosis, and the paralysis is due to the pulmonary tuberculosis. As you can see in this table, regarding voice outcome, we observe a significant improvement in voice handicap index after surgery. Objective acoustic analysis also demonstrate improvement in several parameters. Although some acoustic variables showed modest changes, the overall trend demonstrates better voice quality and improved glottic efficacy after medialization. Respiratory capacity and function, phonatory performance, resonance, practice, frequency, intensity, instruction, and vowel selection are factors that influence maximum phonation time. Therefore, a large number size would provide a more accurate evaluation of these outcomes. In auditory perceptual evaluation using the GRBAS scale, all major domains involved improved after surgery. Patient demonstrated a clear voice quality, reduced breathiness, and better overall phonatory performance. This improvement was statistically significant and remained stable during follow-up. This slide summarizes the key findings for our study. Voice handicap index improved significantly with approximately 78% reduction after surgery. Harmony to noise ratio also improved significantly at 6 months follow-up. And clinically, both dyspnea and aspiration symptoms decreased markedly after the procedure. Importantly, no graft extrusion or major complication was observed. This finding suggests that endoscopic medialization laryngoplasty with autologous nasal septal cartilage is safe and effective with minimally invasive and cosmetic favorable. In addition, autologous cartilage demonstrates excellent biocompatibility and stability. And finally, it supports modern minimally invasive laryngeal reconstruction. In our study, we have several strengths, including prospective design with serial follow-up, comprehensive subject and objective voice assessment, novel endoscopic autologous cartilage technique, and finally, it will be a minimally invasive approach with favorable safety profile. However, limitations include small sample size, single center experience, absence of control group, limited long-term follow-up duration. Endoscopic medialization laryngoplasty using autologous nasal septal cartilage appears to be a safe and effective alternative to external thyroplasty. The procedure results in significantly improved in voice quality, glottic closure, and swallowing-related symptoms. So, it's promising minimally invasive alternative to external thyroplasty again. Here I can play a short video of the procedure. First, we have a measurement of anterior commissure to vocal process distance using a ruler. After that, we have injection of lidocaine and epinephrine. Then we have superior cordotomy incision lateral to the TVC without any interaction with the mucosal layer, and we have dissection and create a pocket in the thyroaryngology vocalis complex. After dissection, we put the first strip 3 millimeters in the pocket, anterior to the posterior. As you can see, it's very hard. Now we put the second graft with shorter length and similar widths in the pocket from anterior to the posterior medial is as needed. And finally, we suture the incision. As you can see in this video. That's the final result. As you can see, because of no intervention in mucosal and lamina-properial layer of TVC, we didn't have significant difference in acoustic analysis that we can see in the other surgeries of this layer like polyp-resection of TVC. Thank you very much for your attention. I would like to express my sincere gratitude to my dear Professor Ehsan Khadibi, as well as Congress moderator and organizing committee for making my participation possible, considering the ongoing war condition in my country, Iran. Thanks very much.
Hello everyone. My name is Jasmine, and I am assistant of Professor Huram Karabayev. Currently, Professor is performing Hajj, and now he's out of connection, unfortunately. So he requested me if I could perform his presentation, if you don't mind.
You want us to share the slides?
No, I have the slides.
Yes, you
but...
can do. You can do the presentation, no problem.
Thank you very much. Can you see my screen?
Yes.
So, wait a minute. So today I'm gonna tell about the studying of sensory neural hearing loss in children associated with toxoplasma and cytomegalovirus infection. And actually, this is a common work of two important doctors. And the first one is, of course, Professor Huram Sankulovich Karabayev from Tashkent State Medical University, and his colleague from Samarkand State Medical University, Associate Professor Munisa Mansurovna Karimova. And they did this work together. So if you let me, there will be two names of them. Unfortunately, Munisa Mansurovna is out of connection as well. She was called by important business trip, and she cannot connect. So let me start. Our topic will be results of clinical and audiologic study of sensory neural hearing loss combined with toxoplasma and cytomegalovirus infection. Let me tell some about sensory neural hearing loss, or SNHL. This is now a very common issue in pediatric otorhinolaryngology. In many countries, we still face the sad situation of children who suffer from hearing loss. One of the leading reasons of this in pediatric practice is toxoplasma and cytomegalovirus. And I'm not talking about congenital CMV. I'm talking about the one which was got after the birth. So this is very important to be able to diagnose early as well as treat professionally, because we are seeking for the child to have a normal hearing in appropriate age, so mostly like till 5 years old, because in this age the child develops speech, right? So it's very important, and of course by diagnosing and treating it in time, we prevent long-term neurological complications. Why did we perform this study? We wanted to define clinical manifestations, audiological characteristics, and severity patterns of SNHL in children who have toxoplasmosis and CMV. In this presentation, I'm going to tell shortly about our study, which was dedicated to hearing loss in toxoplasmosis and CMV. In general, we took 150 children who had the infections and 30 children who had not, but both of these groups, they had hearing loss, sensory neural hearing loss. And we divided them into main group and comparison group. And we studied children from 1 to 7 years old, I want to mention, which were also divided to two groups, from 1 to 3 years old and from 3 to 7 years old. Because in these stages, they have different speech development as well as psychological. So what kind of methods we used in our study, of course, we used auditory brainstem response, which are ABR. We also used OAE, or otoacoustic emissions. We performed tympanometry, PCR diagnostics, and endoscopic ear examination. So all these complicated examinations together allowed us to completely understand the nature and the clinical manifestations of sensory neural hearing loss in children with these two infections. And this was quite a big study, which took a long of time, as you understand. So, but what kind of children were excluded from the study? Children who had hereditary predisposition to hearing loss, who had CNS disorders or any congenital anomalies, which include earway or any traumas, also chronic disease, chronic otitis, acute otitis, children who were administered any ototoxic medications, such as antibiotics, for example, and those who were born from relatives, whose parents were close as relatives. And these children were excluded from our study. So what kind of audiological manifestation we had here? Our ABR test included latency of waves 1, 3, and 5. We also checked interpeak intervals, intensity, latency function, interaural asymmetry, and we added some more tests to clarify our studies, such as OAE for cochlear hair cell function and tympanometry, so we could exclude the middle ear pathology, because middle ear pathology would make us exclude these children from the study. So by studying all these mentioned tests, right, we could determine which children exactly we would include in our study, and which children could be described about sensory neural hearing loss. So what kind of things we needed to check first? To include the child into our study, we performed PCR detection test by finding the proteins of toxoplasma and cytomegalovirus in their blood. This PCR test allowed us to find DNA of the infections and automatically include these children into our study. We used a special system of amplicins. This is, as you can see on the picture on the right, this is pharmacological test that allows us to determine the presence of infections. And for sensitivity, we use 400 copies per milliliter. We also studied the clinical manifestations. So SNHL usually includes delayed speech development, because child cannot hear. They cannot also develop normal speech, and this is quite a dangerous condition. In case we don't help in time, we will lose the ability to speak. Psychomotor retardation, hyperexcitability, sleep disturbances, asthenic syndrome, and recurrent respiratory infections. So unfortunately, these children suffer from many conditions here, as you can see, not only because of hearing loss itself, but also because infection persists in our immune system, so it affects mostly CNS, of course, and really disturbs child to live ordinary. And also we can see several neurological signs such as cognitive impairment, emotional ability, coordination disorders, and muscular hypotonia. Unfortunately, this all together really affects child's life, and as a specialist, it's our duty to notice this all early and be able to help. So by studying the two groups, we got following results. I mean, as you can see, you know that we have 4 grades of hearing loss, like 1, 2, 3, 4, according to the amount of hertz and decibels that they can detect. So in our studying, I will show you in advance that there are 2 systems, as you can see. Here we divided main group and comparison group from the age 1 to 3, here and here. And on the next slide, I'm going to show the main and comparison group divided into the ages 3 to 7. So according to our studying, in the main group, there were following percentage found in particular grades. For example, in grade 1 found about 15%, grade 3 like 46%. As you can see, it was major. Mostly in this age, there are children who have 3rd grade of hearing loss. And in the comparison group, you can see that 2nd grade prevails here. So in the comparison group with children who have no cytomegalovirus and toxoplasma, they have better hearing. And here you can see the worsening, like really noticeable percent. And on the pictures, you can see the results of particular tests, like if they can hear particular words, or they can answer, they can vocalize. You see the amount of children who react and don't react to parents, for example. So this is all variety of hearing tests that we performed. I hope you could read it. So let's see the next one. So what we observed in all these children, but first please look at these following pictures. Here is the group 3 to 7 years in main and comparison groups. So as you can see that there are really a lot of children who experienced 3rd degree as well. Here you see this orange one, and following by the 2nd degree. And in the comparison group as well, they had mostly 3rd degree. So the picture is all really sad. What we could observe, what we could find in this complicated studying, so mostly in our studying, we could not detect the unilateral cases of hearing loss. All of them were bilateral. So we didn't have children who can hear only to 1 ear, or several bilateral hearing impairment predominated, as you can see on these and previous pictures, that grade 3 is the most common. Grade 3 is the most common here. And as I said previously, all cases were bilateral. So otoacoustic results here, you can see our results in numbers. According to the test, all the children failed it. And if you can see the numbers and understand, then our indicators, these results, they indicate that outer hair cells were damaged. So you can see their dysfunction. You can also understand that there is a presence of cochlear sensory damage and hearing loss exceeding 30 decibel. So you can see the results here. This was found in our study by performing all the tests I mentioned below. ABR characteristics. This is not our picture. This is like a scheme. You can see that this is a classical picture of hearing loss in ABR. And how are they characterized? They are characterized by prolonged from first to third interpeak interval. Also in hearing loss, you can see the delayed third and the fifth wave latencies, slowed neural conduction between the cochlea and brainstem. So our studying allowed us to understand that here is not only the cochlear part itself, also we suggest that brainstem was involved in the damaging. So it's not only just neural hearing loss, it's central also. Why is this so important? Clinical significance, all of this. Clinical significance of hearing loss in association with toxoplasma and CMV was characterized by severe bilateral hearing impairment. So all the cases, they were bilateral. Neurological dysfunction. These children, as you could see, they really suffer from sleep disturbances, from various neurological conditions, and it's not only organic, right? There's also psychological dysfunction here, delayed speech and cognitive development, as well as child cannot hear in time. Will not be able to repeat the words after adults, to just even study in kindergarten or school properly, and this will really affect their intellectual development, because, as you know, we all get information from sounds, mostly from sounds. Even if you see something on the picture, you should complete it by the sound. So these children will delay in cognitive development. And clinical implication of this requires from us multidisciplinary assessment. It's not only ENT specialists who must work with these children, also neurologists, of course, as well as speech specialists and pediatricians. They all must see these, and of course, infectionists, of course. They all must treat these children together, because this problem, it's infection, but it damages so many features of child's life. Early audiological screening. We know that for newborns in many countries, we have developed audiological screening that allows us to understand the level of hearing in babies, but it's offered that children of early ages should all sometimes go through the hearing tests, especially if there are any neurological or intellectual delays, because you never know. Maybe this child just has a hearing loss of some low degree and they just don't hear you. And timely rehabilitation and hearing support. Of course, if there is no chance to heal the hearing by medications and surgery, of course, there can be a necessity of hearing apparatus and hearing device. And the earlier we complete it, the earlier we'll be able to teach a child normal speech and intellectual development appropriate for their age, not just normal. So I want to finish my presentation, their presentation, sorry, by the following conclusions. As you could see, that in most cases, third grade of hearing loss was predominant. In all ages from 1 to 3 and 3 to 7 years old, it was predominant. All patients experienced bilateral hearing impairment. Unfortunately, we never met unilateral. ABR and OAE tests demonstrated high diagnostic value. We could understand whether the center was involved or it was just the hearing pathway. Unfortunately, in our study, we detected big involvement of central nervous system, and toxoplasmosis and CMV infection significantly contribute to pediatric SNHL. Because these diseases are common among children and they affect the brain stem, but unfortunately, this infection also spreads to the hearing, and it can damage our hearing way with no healing chance. Early diagnosis is critical for improving speech and neurodevelopmental outcomes. Of course, we were talking mostly about children to 5 years old, who should develop their speech, but the earlier the better. We cannot delay the rehabilitation of hearing and intellectual education, because this is the future of the child. If they cannot hear now, unfortunately, they will not have appropriate future, because this is infection. It's treatable. It's curable, right? So the earlier, the better. Thank you so much for attention. I'm sorry if my performance was some kind of mistakable, because I'm assistant. Our professor is away from here. But if you will have any questions, I will leave his email in the chat, and you could send this to him officially. Thank you so much for your attention.
In this presentation, we will discuss the historical evolution and the modern role of surgery in the multidisciplinary management of head and neck cancer. Over the past decades, head and neck oncology has shifted from aggressive radical surgery towards a personalized multidisciplinary approach integrating surgery, radiotherapy, chemotherapy, immunotherapy, and minimally invasive techniques. Despite major advances in non-surgical therapies, surgery continues to play a central and evolving role in treatment, reconstruction, rehabilitation, and salvage management. This presentation highlights the major historical milestone, current indications, modern technological advances, and future perspective of surgical management in head and neck oncology. The history of head and neck cancer treatment began with surgery as the only available curative option. One of the earliest milestone was the first total laryngectomy performed by Theodore Bilthoff in 1873. Later, George Cryle introduced the radical neck dissection technique in 1905, establishing the foundation of modern cervical oncologic surgery. Major medical advances following World War II, including improvements in anesthesia, antibiotics, and blood transfusion techniques, significantly reduced surgical morbidity and mortality. Over time, surgical management evolved from highly aggressive ablative procedures toward more conservative and function-preserving approaches. This transition marked the beginning of modern multidisciplinary and head and neck oncology. Over the second half of the 20th century, head and neck cancer management gradually shifted from isolated surgical treatment towards multidisciplinary care. The integration of surgery, radiotherapy, and chemotherapy significantly improved locoregional control and patients' survival. This evolution led to the establishment of multidisciplinary tumor boards where surgeons, radiation oncologists, medical oncologists, radiologists, and pathologists collaboratively determine optimal treatment strategies. At the same time, organ preservation protocols fundamentally changed treatment philosophy, particularly in laryngeal and oropharyngeal cancer. Modern head and neck oncology is now based on personalized treatment planning that balances oncological control with functional preservation and quality of life. The development of radiotherapy and chemotherapy dramatically changed the treatment paradigm of head and neck cancer. Following the introduction of cobalt therapy units and later linear accelerators, radiotherapy became an effective curative modality for multiple head and neck tumor sites. Technological advances such as intensity modulate radiotherapy or IMRT significantly improved tumor targeting while minimizing toxicity to surrounding tissues. At the same time, platinum-based chemotherapy, particularly cisplatin, became the cornerstone of systemic therapy. The introduction of concurrent chemotherapy protocols improved locoregional control and enabled organ preservation strategies, especially in laryngeal cancer. These advances established the modern multimodal treatment era in head and neck oncology. During the 1990s and early 2000s, organ preservation emerged as a major goal in head and neck oncology. Landmark clinical trials demonstrated that selected patients with laryngeal cancer could achieve comparable survival outcomes without total laryngectomy. As a result, concurrent chemoradiotherapy protocols become widely adopted in organ preservation strategies. This marked a major shift from purely survival-oriented treatment toward approaches that also prioritize speed, swallowing, and overall quality of life. Nevertheless, careful patient selection remains essential since not all tumors are suitable for non-surgical management. Modern treatment planning, therefore, aims to balance oncologic safety with functional preservation. Technological innovation has profoundly transformed surgical management in head and neck oncology. Transoral laser microsurgery represents one of the first major advances towards minimal invasive surgery, allowing precise tumor excision with reduced tissue damage. More recently, transoral robotic surgery, or TORS, revolutionized the treatment of selected oropharyngeal and upper digestive tract tumors. Robotic systems provide enhanced visualization, improved instrument dexterity, and access to anatomically challenging regions. These techniques significantly reduce surgical morbidity, hospitalization time, and functional impairment compared with traditional open surgery. As a result, minimal invasive surgery has become an increasingly important component of modern multidisciplinary head and neck cancer care. Modern reconstructive surgery has dramatically improved outcomes following a major head and neck cancer resection. The development of microvascular free tissue transfer revolutionized reconstruction by allowing immediate restoration of complex surgical defects. Today, reconstruction aims not only to close the defect but also to restore speech, swallowing, mastication, facial symmetry, and overall quality of life. The fibula-free flap has become the gold standard for mandibular reconstruction because of its excellent bone quality and versatility. In addition, CAD/CAM technologies and virtual surgical planning have significantly improved reconstructive precision and functional outcomes. Modern reconstruction, therefore, represents a fundamental component of multidisciplinary head and neck oncology care. Despite major advances in non-surgical therapy, surgery continues to play a central role in the management of head and neck cancer in 2025. Surgical treatment remains essential for resectable tumors and is increasingly guided by personalized oncologic assessment and multidisciplinary planning. Modern surgical techniques aim not only for oncologic control but also for preservation of speech, swallowing, facial appearance, and overall quality of life. At the same time, surgery is now closely integrated with radiotherapy, chemotherapy, targeting therapies, and immunotherapy within comprehensive treatment strategies. Technological innovation, including robotic surgery, navigation systems, and virtual surgical planning, continues to expand the role of surgery in contemporary head and neck oncology. Despite advances in multimodal therapy, local regional recurrence remains a major challenge in head and neck oncology. Salvage surgery continues to represent the primary curative option for selected patients with recurrent disease following radiotherapy or chemoradiotherapy. However, recurrent tumors are often associated with fibrosis, distorted anatomy, poor wound healing, and increased post-operative complications due to previous treatment. Therefore, careful patient selection and multidisciplinary evaluation are essential before considering salvage procedure. Modern reconstructive techniques and perioperative rehabilitation strategies have significantly improved functional recovery and quality of life after salvage surgery. Nevertheless, these procedures remain technically demanding and associated with substantial morbidity. The emergence of immunotherapy represents one of the most important advances in modern head and neck oncology. Immune checkpoint inhibitors, particularly PD-1 inhibitors such as pembrolizumab and nivolumab, have significantly improved outcomes in recurrent and metastatic head and neck squamous cell carcinoma. At the same time, molecular profiling and biomarker analysis are increasingly guiding individualized treatment decisions. Precision oncology aims to tailor therapy according to tumor biology, genetic alterations, and patient-specific characteristics. Despite these advances, surgery continues to maintain an essential role within multidisciplinary precision medicine strategies, particularly for resectable disease and salvage management. The future of head and neck oncology will depend on the integration of surgery with immunotherapy, molecular diagnostics, and targeting therapies. The future of head and neck oncology will likely be defined by increasing personalization, technological innovation, and multidisciplinary integration. Artificial intelligence is already contributing to imaging interpretation, surgical planning, prognostic prediction, and treatment selection. At the same time, advances in molecular diagnostic and genomic profiling are expected to further refine individualized therapeutic strategies. Emerging technologies such as robotic surgery, augmented reality navigation, and image-guided procedures may significantly improve surgical precision and functional outcomes. Liquid biopsy and circulating tumor DNA analysis may also enhance early diagnosis, treatment monitoring, and recurrence surveillance. Ultimately, the future of head and neck cancer management will depend on the integration of surgery, molecular oncology, immunotherapy, and advanced digital technologies within precision multidisciplinary care. In conclusion, surgery continues to play a fundamental and evolving role in the multidisciplinary management of head and neck cancer. Over the past decades, treatment strategies have shifted from radical ablative procedures towards personalized function-preserving and minimally invasive approaches. Technological advances, including robotic surgery, virtual planning, molecular diagnostics, and precision oncology have significantly improved both oncologic and functional outcomes. At the same time, multidisciplinary collaboration remains essential in optimizing survival, rehabilitation, and quality of life. The future of head and neck oncology will likely depend on the successful integration of surgery with immunotherapy, molecular medicine, artificial intelligence, and advanced digital technologies. To summarize, head and neck oncology has evolved into a highly multidisciplinary and technology-driven field. Surgery continues to play a central role, particularly when integrated with radiotherapy, systemic therapy, and precision oncology approaches. Modern techniques such as robotic surgery, virtual planning, and molecular diagnostic are improving both oncologic and functional outcomes. At the same time, preservation of speech, swallowing, appearance, and overall quality of life has become increasingly important in treatment planning. Ultimately, future advances will depend on the successful integration of surgical innovation, molecular medicine, immunotherapy, and artificial intelligence within personalized multidisciplinary care. Thank you very much for your attention.
Hello all, I'm Harmeen, a resident doctor based in the UK. Today I will be presenting a unique case of granular cell tumour of the esophagus, which highlights the challenges of referrals with single static imaging. So we'll just turn to the next slide. Sorry, how do we, yeah, perfect, yeah. We shall begin by going through the patient history. So a 20-year-old female was referred from primary care, so the GP or family medicine, to secondary care ENT department. Her past medical history included asthma and PCOS. Her main presenting complaint was a 4-month history of intermittent dysphagia and a firm anterior neck swelling. Her bloods, including thyroid function tests, parathyroid, and calcium levels, were all within normal range. If we just go on to the next slide, we'll get the initial ultrasound here. So this is the initial first ultrasound image that was sent from the GP to our ENT department, and it revealed a well-defined hypoechoic nodule that measured 30 by 13 millimeters. And this nodule was posterior to the left thyroid lobe, with clear separation from the thyroid gland, with no pathological lymphadenopathy. This initially suggested a parathyroid lesion, and then we did a CT scan. If we just get onto the next slide. Yes, so this CT scan pointed out by the orange arrow shows similar radiological appearances to the initial ultrasound. So essentially it showed a nodule behind the thyroid gland. And then next slide, please. Yeah. And then next we did a PET CT scan, which showed, as you can see with the yellow uptake, a lesion in the tracheoesophageal groove posterior to the middle third of the left thyroid lobe, which it partially effaced. Again, this lesion measured 16 millimeters in maximal dimension, lying 21 millimeters deep to the skin surface. At this point, we were thinking the differential diagnosis could be an anterior esophageal wall mass, such as a leiomyoma. However, despite its anatomical location, the parathyroid pathology was considered less likely due to a normal parathyroid hormone level. So the initial diagnosis that we were thinking with a parathyroid lesion was becoming less likely because of the normal PTH level, even though the ultrasound and the radiological imaging did suggest a parathyroid lesion. And then next slide, please. So following an MDT discussion, it was decided it would be best to do a surgical exploration of the left central neck and a left hemithyroidectomy in case it did originate from the thyroid itself. Intraoperatively, a solid mass with cartilaginous consistency was identified deep within the level 6. This mass was adherent to the esophageal muscle, raising concern for local invasion. So a frozen section was performed intraoperatively to get a quick result in the histology. This locally invasive behavior raised concern for malignancy, prompting the surgical team to ensure wide surgical excisions were achieved with clear margins. As a consequence, due to the surgical team wanting to do, a wide surgical excision, the patient had a small perforation of the esophagus, which was promptly repaired with sutures. Histopathology showed a benign mass, but locally extensive infiltrative granular cell tumor with normal thyroid tissue. Next slide, please. So post-operatively, the patient was placed nil by mouth and a nasogastric feeding tube was inserted, and she was managed conservatively with IV antibiotics and steroids. She stayed in hospital for a few weeks once to make sure that the perforation had resolved. After 1 month, a water-soluble contrast swallow was performed, which confirmed that the perforation had healed with no leak. The MDT recommended imaging surveillance to monitor for recurrence. So it was suggested that she should get an MRI neck done at 3 months post-discharge, which she did get done, and it confirmed no definitive residual tumor. Clinical evaluation 3 months post-operatively confirmed normal vocal cord movement, and she continues to await post-operative ultrasound surveillance. Next slide. So what are granular cell tumors was my first question, because it's not something I had heard of previously. So we'll just go through some of the background of granular cell tumors, epidemiology, histopathology, and the general management of them. So granular cell tumors are rare soft tissue neoplasms of Schwann cell origin. They most frequently involve the deep dermis and the subcutaneous tissue. The single most common site is the tongue, representing 25% of cases, followed by the breast. Granular cell tumors occur twice as often in females as in males, but are most often diagnosed in the 4th to 6th decades of life. So our patient was quite young compared to the normal population that often get granular cell tumors. These tumors are rare. According to a review, granular cell tumors accounted for 0.03% of all surgical specimens. So this is a diverse anatomical site rather than just the esophagus itself. So we can imagine how rare granular cell tumors of the esophagus are. So there are currently 270 reported cases of esophageal granular cell tumors, accounting for approximately 1% of all benign esophageal tumors. Most esophageal granular cell tumors are asymptomatic, and they're normally discovered incidentally during endoscopy. Definitive diagnosis relies on histopathology, which was shown in our case. Immunohistochemical staining usually demonstrates strong positivity for S100 protein and the CD68 protein. And ultrasound imaging, as shown in our case, lesions usually appear as small, well-defined nodules. And the main treatment of choice is wide local excision, because granular cell tumors are poorly encapsulated. Therefore, they demonstrate infiltrative growth patterns, just like in our patient. Again, like all cancers, management depends on tumor size, symptoms, and histological findings. So lesions measuring less than 1 centimeter without histological evidence of malignancy may be managed conservatively with endoscopic surveillance. Larger lesions that measure more than 2 centimeters are typically removed during endoscopy. Resection is also indicated for tumors if they're symptomatic or demonstrate malignant features. So just next slide, please. So with our patient, these were the main differential diagnoses the team were thinking about. Their differential diagnoses included the thyroid and esophageal pathologies. So Hurtle cell neoplasms of the thyroid, they're usually typically composed of more than 75% large polygonal cells with well-defined borders. Thyroid schwannomas are benign and of neural origin. However, they lack the granular cytoplasm characteristic of granular cell tumors. Medullary thyroid carcinoma is classically associated with elevated calcitonin levels, which our patient did not have, and the presence of stromal amyloid deposits on histology, which are not classically observed in granular cell tumors. So what I'm trying to get here is that the main way we can confirm a diagnosis is with histopathology analysis. So in this patient of ours, the histological analysis showed a tumor composed of polygonal cells with round to oval nuclei, and ample granular eosinophilic cytoplasm, hence the name granular cell tumor. And they're classically, like I said before, a positive for S100 and CD68 proteins. Favoring the diagnosis of granular cell tumor. So next slide, we'll just go through the challenges and the highlights here. So this case for us highlighted a rare cause of dysphagia secondary to a benign yet infiltrative esophageal granular cell tumor in a 20-year-old woman. It highlights several diagnostic and logistical challenges commonly encountered in a tertiary referral centre, particularly when evaluating rare tumours such as GCTs in anatomically complex regions like the thyroid or esophagus. So my department is a tertiary centre in the Midlands of the United Kingdom. Like I said, we got a referral from the GP or family medical team with the one ultrasound image. And this static singular ultrasound image was difficult to interpret. And it shows the importance of the repeat imaging that we did with the CT and the PET-CT scan in specialized centers, preferably by experienced radiographers familiar with rare head and neck tumors. So this case highlighted the importance of repeat imaging and multimodal imaging, so CT and MRI at tertiary centers, where we have an access to expert pathologists and radiologists. So it shows how important expertise is, especially for accurate diagnosis and optimal management. Next slide, please. These are the references used in this case, particularly for the background and epidemiology of granular cell tumors. Next slide, please. Thank you for listening. I hope you enjoyed that case. If you have any questions, please just unmute yourselves and put your hand up.